Hello, everyone. I'm Lindsay Joseph, the LINCS Program Officer, and I'd like to welcome you to the LINCS webinar on COVID-19 and the global CVH community. These are unprecedented times we're living in, and I'd like to thank you all for taking the time to participate in this webinar and learn more about how we help keep ourselves and each other healthy and safe. Before we begin, I'd like to review a few housekeeping rules. The presentation will be about 15 minutes long, followed by a Q&A session. We encourage participants to use the Q&A button and not the chat feature to ask questions. The Q&A button is located at the bottom of your screen. Participants will be muted for the duration of the webinar, but will have the option to type in questions for the Q&A portion. The webinar is being recorded and will be posted to the LINCS website following the session. As COVID-19 continues its global spread, we want to provide the LINCS members with an opportunity to learn more about the pandemic and gain a better understanding of what impact it may have on the global CVH community. Adults with hypertension, diabetes, and other chronic non-communicable conditions may be especially vulnerable to coronavirus. Although the coronavirus pandemic will certainly get worse before it gets better, it will get better. We must be proactive now to limit the harms of COVID-19 to achieve the three overarching goals of the response: to reduce infections, improve health outcomes of those infected, and reduce societal harms. Today's presenter is Amanda McClelland, Senior Vice President of Prevent Epidemics at Resolve to Save Lives. The Prevent Epidemics unit at Resolve is working around the clock to analyze the data as they become available and mobilize rapid support to partners and countries to strengthen their response. More information can be found on their website, preventepidemics.org. I'll now hand it over to Amanda to provide an update on COVID-19, what we know, and what we can do to protect ourselves and each other.
Great, thanks so much, Lindsay. As Lindsay said, my name is Amanda. I'm the Senior Vice President of the Prevent Epidemics team. And we're going to give an overview today of COVID, and then hopefully be able to answer some questions and provide some guidance in terms of next steps. So overall, you will have seen the global situation continues to rapidly change. We have more than 167,000 confirmed cases now globally, with more than 6,500 confirmed reported deaths. The case fatality rate overall is 3.9%, and we have more than 100 countries regularly reporting cases now. Next slide. So you can see the rapid increase in the number of countries reporting. This graph shows the countries that are reporting active transmission. You can see the large increase in Europe there, really driven by the cases coming out of Italy, but we have every region in the world now reporting cases of COVID. This is an overview of the epi curves. You can see there has been some success. If we look at the South Korea up in the top left-hand corner, very large spike in South Korea, but effective non-pharmaceutical interventions, including cancellation of mass gatherings and sheltering in place, really helped drive down the curve very quickly there, and large-scale lab testing. In contrast, you see Italy and Iran still with exponential growth in terms of numbers there, reporting more than 1,500 cases a day. They too have now put in very strict non-pharmaceutical interventions, meaning they are asking people to shelter in place. Iran today released all prisoners.
I don't understand why it always changes my
settings
to have the speaker be speaker from this fucking monitor. I'm not.
Are we good? Yeah, so Iran also seeing exponential growth, also Spain, USA, Switzerland, so a number of countries now having large amounts of community spread. But as I said, we have seen some countries turn the curve, specifically China and South Korea, with aggressive and early MPIs. The situation in Africa, we have now 347 confirmed cases. There's a lot of areas in Africa still not reporting any cases, and we still don't see large-scale active transmission. We're not 100% sure why. Some of it has to do with lab and surveillance capacity. Some of it may have to do with disease transmission and dynamics, but we do expect to see a large number of African countries increase transmission in the coming days, if not weeks. So what do we know about COVID? This is a rapidly evolving situation, and we're learning more about the disease and the disease transmission dynamics every day. But so far, it's very clear that this spreads from person to person. The spread within healthcare facilities remains a major source of spread, just as it was for MERS and SARS. So we have seen large super spreading events occur, and we have seen healthcare workers become infected. We're seeing both inter-household transmission at high levels and also ongoing community spread. We know the disease can cause severe illness, especially among the elderly and people with underlying health conditions. And this is an unprecedented pandemic continuing to spread in many countries around the world, requiring urgent and aggressive action to slow it down. So the team has been working in terms of trying to get an understanding about how severe the pandemic will be, and we use two measures for this. The scale of clinical severity, you can see along the bottom line there, and then the scale of transmissibility. And this graph shows where other pandemics have sat in the past, including the most recent one in 2009, the H5N1 pandemic, there between low to moderate severity. The purple boxes show our current estimates of where this outbreak, this pandemic will sit. And because of the difference that we're seeing in age groups and underlying conditions, we've boxed it out to see the different impact across the age demographics. So you can see up in that right-hand corner, a very severe pandemic for people over the age of 60 or with underlying conditions. We're seeing high attack rates and high disease severity in that group. We see lower severity of diseases between 20 and 59, but still a significant pandemic in that age group. And then the ages 0 to 9, we're seeing a lot less transmission and severe disease, but there's still a lot of research going into this, and new data is coming out in the last few days. And so there's still a lot we don't know about the transmission, especially in those lower age groups. And there's a lot of work going on at the moment to understand that. So what we still need to know, how readily this disease spreads, especially at community level. We need to know how deadly it is. So the case fatality rate, although we're reporting cumulative at 3.9%, we see a big difference in different countries. Singapore essentially has had no deaths, even though they've had over 100 cases. They have good access to high-level critical care. We've seen countries like Italy and Iran that have become overwhelmed with cases have very high case fatality rates, but also we're missing a large percentage of the denominator. And so without enough lab facilities, obviously that denominator is not capturing all of the cases, especially given that we think up to 80% of cases are mild or asymptomatic. So we still really don't know what the case fatality ratio is across the whole community. And we still have limited evidence about how we can limit the risk. So there's extensive use of MPIs that seem to be showing impact, especially in China and South Korea, but those interventions come with large social and economic costs, and what that looks like in multiple countries at the same time or low middle income countries is difficult to judge. And so how we can limit the risk but also limit the impact of those measures is still something that we need to investigate further and learn as we go. But the overall approach is really about flattening the curve. Given the disease transmission at the moment and the number of countries infected, the overall approach for most countries is around flattening the curve. And that's really to avoid that large peak that you see there in the dark purple, and flatten out the curve so that the number of cases don't overwhelm the health system capacity. If we can maintain essential health services, we can maintain access to critical care, we can lower the case fatality rate, protect healthcare workers, and maintain essential services. So the approach in most countries now is around using MPIs and other measures to flatten the curve to maintain capacity. So we're learning a lot every day. What we're learning is that the spread within healthcare settings remains a major risk and a major intervention point for control. And this isn't just within emergency departments or for COVID-specific patients. We need to make sure that we're protecting the whole health system, given that we have a limited testing ability in mild cases. We know the incubation period averages 5 to 6 days, but ranges from 2 up to 14 days. And we know without control measures, each confirmed case infects approximately an additional 2.6 people, which is a high number, consistent with the rapid spread that we've seen. We also have learned many lessons from China, that with extraordinary efforts, we're able to contain the virus using a containment strategy to limit the speed of the spread and full containment. But full containment of COVID does not appear possible. We know people over the age of 60 with underlying conditions have the highest risk of death, with the case fatality rate in that age group being very high. And we know the challenges with COVID care is really that 10 to 20% of cases that we're finding require hospitalization. 5% of them require ICU care. And one of the most difficult things for the healthcare facility, the health system to manage, is people are requiring a long length of stay, 12 to 21 days in hospital. And this really puts a massive burden on the health system in terms of managing cases. So in terms of response, there's a range of response tools that we call adaptive response, which really range across disease control, non-pharmaceutical interventions, and then of course the pharmaceutical interventions, and spread from what we call containment, where we're trying to lock down clusters of cases and introduction of the disease into new areas, moving into mitigation once we have widespread community transmission to try to flatten the curve. So the focus is really on early detection, especially lab diagnostics, clinical diagnosis, and home isolation. A real focus on contact tracing in the beginning, but at some point, once you get large amounts of transmission, the contact tracing adds very little value and is resource heavy. And so potentially the contact tracing stops once you get a large amount of transmission. We need healthcare infection prevention and control before the outbreak even occurs and all the way through to the end. Protecting healthcare workers and health systems remains the priority across the spectrum of countries responding. We need to provide the appropriate level of clinical care, and community engagement is critical. Early and consistent risk communication from the very beginning about the risk and the ongoing information updates, including how they can access care, the standards of care, where to go for testing, where to go for treatment, but also the importance of flattening the curve and social engagement is extremely important. And we see countries that are consistently and clearly communicating the risks doing much better than countries where the risk communication is not as effective. We need everyday personal MPIs from the very beginning. So promoting washing hands, covering coughs, staying at home, if you're unwell, not shaking hands. These are all things that we should be promoting across the full spectrum of the outbreak. And environmental MPIs, cleaning surfaces, increasing ventilation. But then once we get to community level transmission, it's really time to implement what we call pandemic personal MPIs and community MPIs. And this is really limiting the movement of people who are high risk, advocating for people with comorbidities and elderly patients to stay at home, to stay away from young children and potential people that may have come into contact with the disease. And in terms of community MPIs, really promoting teleworking, remote meetings, avoiding mass gatherings. We've seen restaurants and nightclubs closed. We've seen limited schools closing across many countries. We're seeing churches and mosques adapt the way that they provide services to make sure that social distancing is in place. And this is the main tool that many countries are using right now, and what we refer to as flattening the curve approach. And then obviously there's pharmaceutical interventions, and there's a lot of trials going on at the moment, but we don't foresee specific treatments coming in, at least for several more weeks. And then obviously a vaccine is more than 12 months to 18 months away, even though we've seen some early reports of potential candidates. It will take some time for full testing, and then obviously production and distribution. So a range of activities across the curve, moving from containment to mitigation and potentially back to containment as caseloads come down. So what to do? I think the main message is everyone has a role to play in limiting the spread of COVID. So everyone can focus on washing their hands, covering cough and sneezes, practicing social distance, but particularly supporting the older people in our community and those with underlying diseases, promoting the fact that they should secure 3 months of supply of essential medicines. This is both to stop them having to go to the pharmacy where potential exposure would occur, but also making sure that they don't have to come to the doctor regularly, to be in waiting rooms and to take up valuable healthcare worker time. They should stay home as much as possible, avoiding crowds, cruises, and non-essential air travel, and have a plan for caring for a sick loved one or being cared for. Healthcare providers obviously have a key role here. There's a need to ramp up and support rapid training for implementation of improved infection control procedures in the whole health system, not just the system responding to COVID. Be ready for a surge of people with mild symptoms and how you'll maintain essential care, and prepare for an increase in the number of patients supported with intensive care, including ventilators. And potentially, restricting non-essential health services or cancelling elective surgeries in some cases. In terms of society and government, is a really important approach to provide clear, credible, and consistent information about the virus and the response, and to be able to recognise that we will need to adapt our response as we learn more around the virus and it continues to spread. And also to mitigate the negative impacts of the MPIs, so to make sure that people aren't economically or socially impacted too heavily. So we see a number of governments now with economic stimulus packages and other approaches to protect from those negative impacts. So immediate and sustained support will reduce COVID right now and reduce the risk of future epidemics as we move forward. So the Prevent Epidemics team, we've been working for several years now on helping countries build capacity to be able to find and detect earlier. And although we're moving to emergency response now, we can still build in those systems that are required longer term. So really improving our ability to comprehensively track diseases and contact trace, make sure that we have functioning labs that are connected with good lab transport systems, and make sure that we have a workforce of trained disease detectives to support early detection and response. And we can really, improve our ability to respond to these threats with improved emergency plans and procedures, not just at national level, but in each facility, each each hospital, each private clinic, having an emergency plan and procedures in place, especially for IPC, having access to emergency response teams that can move quickly and efficiently, having the right public health legislation in place, and we're seeing how important that is right now as governments implement MPIs, and really importantly, comprehensive and clear risk communications. So there's a number of resources, and the team will share these out, but obviously the Prevent Epidemics team is keeping a website up to date that helps us cover epidemic insights and sharing critical documents and information. The WHO teams are putting out a lot of technical guidance and regular situation updates. CDC has some great resources, especially for health facilities. John Hopkins is creating regular health security situation updates and have a reliable dashboard to show the overall caseload and spread. So I think I'll finish off there. I'll throw back to Lindsay. I'm happy to answer any questions. And
hi, this is Tom Frieden. Can you hear me?
yes, Tom, we can hear you.
Okay, I just wanted to make a couple of comments before we throw it open for questions. First off, to welcome everyone again to the webinar and recognize that we are really in an unprecedented time as the pandemic spreads around the world. It will be a particular challenge to people with chronic disease. And that includes many of the people we serve with hypertension, many of whom also have diabetes. So we wanted to provide you with this update and this opportunity to answer some questions and address concerns. We know that this is going to get worse before it gets better, but it will get better in the future. And by reducing the harms now and driving down the risk of future epidemics and pandemics, we can hope that some good will come out of this terrible phenomenon. I think the three overarching goals that we have are to reduce the number of infections, improve the outcomes in people who are infected, and reduce the societal harms of the interventions that we implement. For those with chronic disease, this is a particular challenge, and in areas where there is widespread transmission of coronavirus, we're basically encouraging those who do have chronic disease and are older to shelter in place and avoid contact to the greatest extent possible. And that is a particularly important message to give to people. There are two specific resources which you've probably seen, but I want to mention. One of them is a 2-page document, which is now in about 6 languages, about how to deal with the pandemic for chronic disease patients. And Lindsay can provide those, actually 3 documents. A second is a statement that we issued yesterday about RAS inhibitors, ARBs, and ACEs. There have been internet discussions that they might be helpful or harmful for coronavirus, and there is no scientific data to suggest that either of those things are the case. So I would just reassure you that there's nothing, there's no reason for anyone to either go off them if they're on them or go on them if they're off them, other than for hypertension clinical or other medical clinical reasons. And third, we have a simple document that outlines the 4 different areas where people can take action. What everyone can do, which is wash your hands, cover your cough, don't go out if you're sick, and stop shaking hands. What people with underlying illness can do, such as getting 3 months of medication and avoiding contact with others. What healthcare facilities need to do, and this is very important because there's a huge risk that healthcare facilities will be overwhelmed by this and unable to provide care safely. So the core concept here is to be ready to surge safely without risking infection to patients or healthcare workers, and being able to be ready for large numbers of patients or for large numbers of patients who need intensive care, and then for society and government to be ready for broader action which may limit impact of the virus. So I'll stop there. We have a lot of questions in advance. I'll handle some of them. Dr. Andrew Moran is on to handle some, and Amanda's on as well. So back over to Lindsay to moderate.
Thanks, Tom. Just a note, the documents that Dr. Frieden referenced are available on the LINCS website, both in the LINCS toolkit under the hypertension section and on the LINCS community news page in the section that we have dedicated to coronavirus. Just a reminder that we ask that participants use the Q&A function located at the bottom of your screen to submit questions. We have asked members in advance of the webinar to submit some questions, so we'll get started with some of those. The first question I'll give to either Dr. Andrew Moran or Dr. Frieden. Can you please talk about the effect of ARB medications and what effect that might have on the virus or ACE2 receptors?
So Lindsay, are you able to put on your screen that cartoon of, yeah. Okay, well, this is going back to your clinical training for some of you on the call, but this is just a cartoon showing the pathway of how the molecule angiotensinogen is converted to angiotensin 1, and then it's the enzyme, the ACE angiotensin converting enzyme that converts it to its most active form, angiotensin 2, that has all the effects that we associate with vasoconstriction and high blood pressure. So patients who are taking ACE inhibitors and ARBs, they're basically blocking that first pathway and inhibiting the production of this molecule angiotensin 2, which raises blood pressure. Some of these hypotheses that have been generated, and they're only hypotheses, as Tom Frieden discussed earlier, is that along this pathway, a consequence of these medicines is that this second enzyme called ACE2, which you see on the right of the cartoon, is actually, it may be upregulated. Even that is not certain because some of this information comes from animal studies. So it happens that the ACE2 is also a portal of entry for the virus that causes COVID-19. And so there's a concern that one hypothesis is that this molecule ACE2 is upregulated and enhances entry of the virus into cells. But in fact, there is a counter hypothesis that generation of this ACE2, which lowers blood pressure and counteracts it, basically the molecule that neutralizes angiotensin 2, that it might have favorable effects. So there are two hypotheses out there. One, that ACE and ARBs might improve outcomes in people who are infected with COVID-19, and there's another hypothesis that it might make things worse. But these are both hypotheses, and there's no scientific evidence to support either one. And so the main message that we're promoting is that for patients who are already taking these medicines, they're known to save lives, very effective for hypertension, heart failure with a reduced ejection fraction, chronic kidney disease, and other conditions. Patients should continue to take these important medicines until there's any established scientific evidence or their doctor finds a reason to take them off of them. Over.
Thanks, Andrew. And we will try to make answers to these questions available on the LINCS website following the webinar, in addition to making the recording available. So if you didn't get all of that, we'll try to have written responses available to LINCS members. Another question for you, Andrew. What is the risk for well-controlled type 1 diabetics? If we know the answer, maybe you can speak more to that.
Yeah, so I think some of you may have seen there's a set of case reports. At this point, I think all of them or almost all of them have come out of China in any numbers, and particularly in Wuhan, China, reporting on these case series of patients who were admitted to the hospital with COVID-19 infection. And they have looked at characteristics that cluster in the patients who had the worst outcomes, meaning either intensive care unit admission or death. And there's clearly a pattern, I think, as Amanda McClellan was alluding to, that patients who are older and have chronic medical conditions, including diabetes, hypertension, chronic lung disease, and other comorbid conditions, are much more susceptible to worse outcomes. Now the question had to do with what does it matter if the diabetes is controlled, or you could say if the hypertension is controlled at the time the patient becomes ill. We don't know the answer to that. These case series, they're very crude reports because they were gathered in healthcare settings that were emergency. There was not time to gather a lot of detailed information from patients, and the information system itself wasn't very robust. So in terms of your question about whether it matters if diabetes or hypertension or other conditions were controlled before the infection, we simply don't know the answer. We may learn more as information emerges from countries with more detailed information systems, for example, Italy, Spain, or other European countries. But for now, all we know is that patients who are vulnerable are those who are older and have these chronic medical conditions.
Thank you. Turning to the Q&A chat, some governments, the UK and the Netherlands, are implementing a policy of building controlled herd immunity. Is there sufficient evidence that this is appropriate? Can this approach put the most vulnerable at risk? Perhaps Amanda, you can, or Dr. Frieden?
Maybe I can just briefly comment. I think certainly the UK has backed off that position in the past a few days, and we don't think that's a sensible way to go forward. It is possible that this will spread so widely that herd immunity develops, but we really don't know what's going to happen with this virus. We don't know how widely it will spread or how long it will spread. We don't know whether we will have treatments in the next few months or not, and whether a vaccine will be able to be developed in a year or two successfully. So I think the goal really goes back to that key slide that Amanda showed about an adaptive response, that places should attempt containment as long as possible, and if containment becomes impossible, then go to the community mitigation strategies. And in many countries, that's the place we're at now. It's still not completely clear that it will be impossible to contain this, although it seems extraordinarily unlikely. We look at China, Singapore, Taiwan, Hong Kong, and we see, and South Korea, and we see containment. But whether that's something that can be maintained, only time will tell. Amanda may want to say more on this.
No, I think you covered it.
Thanks, Dr. Frieden. Another question that we have is, how do we avoid response fatigue? When will we know that the health system can handle future infections? There are a few questions here. And is there a threshold of susceptibles? Should we do a community survey to see what the percentage is of the infected, and should we aim to put down each spark that we find? Perhaps, Amanda, you can speak to the response fatigue. We know that this is an ongoing pandemic, and that we'll all have to be at the ready for a very long time, and how we should combat fatigue of responding to the virus.
I think there's a number of different fatigues to talk about. Response fatigue is one. In my experience, it took 2 years to overcome the last two big West Africa Ebola outbreaks, and response fatigue is definitely a part of that. But I think, we see the health system continuing to meet the demands, and I'm very proud of the frontline healthcare workers who continue to work extremely hard as long as there is a need there. I think one of the risks that we have is donor fatigue and community fatigue, that the risk, as we see the MPIs work and we see cases go down, or we don't see exponential growth in some countries, we see communities think that we've overreacted to this, or that the measures are too strict. And so the more success we have in controlling the outbreak, especially early, the more risk we have of the community not understanding the risks and not taking the advice seriously. And so I think we have to manage those three different types of fatigue. I think for my team in particular, I've been making sure that we think of this as a marathon and not a sprint. As much as we are working, 14 or 15-hour days now, we need to maintain this for the next 6 to 12 months in the very least. And so making sure that you're looking after staff's mental health, that you're taking time out to eat properly and exercise, and taking a break away from the front lines, even though the needs are great. Self-care for frontline responders is extremely important, both physically and mentally.
Thanks. We have a few questions on the guidance that has been issued, and if you can speak to school closures and the risk for children. I know you mentioned that a bit, Amanda. And now that schools have been closed and most people are working from home, how do you sort of take care of your family while maintaining the restrictions that have been set in place?
Yeah, so maybe Dr. Frieden can speak to some of the theory behind the school closures. I think there's still a lot we don't know about pediatric transmission and the risk within schools, and there's some schools of thought that keeping schools open. In Australia, I know they're keeping schools open with the idea that they're able to contact trace and look for clusters and not have children kind of going to the park and kind of spread out all over the place. And so parents can maintain services at least until they see transmission occurring within the schools. Other countries have taken the extraordinary step of closing all school for the next month. And in part, this is to make sure that they don't have large, we're recommending social distancing, and obviously schools are mass gatherings. I think there's a couple of things to be careful about. We have seen in some countries that grandparents are then taking over care of the children, and we have seen household transmission. And so understanding the risks that we move from the schools to the older population and how we mitigate that. And obviously there's massive social and economic disruption to closing schools. So the increase on online learning has been significant, and it was working in developed countries, but what does that mean in low middle income countries? I think we're yet to see the impact of that. And then obviously home care, where everyone is working from home but trying to manage children, it's impacting our team. I'm sure it's impacting other teams. And so we've been talking to our teams about mixed approaches, both parents at home, one kind of working, some neighbors getting together, and small groups, 4 or 5 people working from one house while their significant other is in their own apartment caring for their own children, and then swapping that out. Some of our teams are working early in the morning and doing childcare during the day, and then coming back online at night. And for our critical staff, we're looking at providing additional support to help with childcare costs. But closing schools have a significant impact socially and economically. The evidence that they're turning the curve, I think, is still something that we're looking at.
Great, thank you. Along the lines of work disruption and becoming more adaptive to different work scenarios, someone has submitted a question that the NCD programs are taking a back seat during the pandemic, and how do we advocate or advise ministries of health to deal with this dilemma?
So again, maybe I share some of our experience from Ebola. I think this was a mistake that we made in West Africa, was shifting all of the focus to Ebola treatment, and what we saw was increased deaths related to maternity care and to malaria. And I think we will see the same thing here. I think it's critically important that we maintain essential services to reduce morbidity and mortality from non-COVID related diseases. And so the focus from our teams is really how do we help health facilities become as safe as they can be to maintain essential services. But for NCD specifically, this is a high-risk, vulnerable group for this outbreak, and so I think prioritizing NCD work, such as the Resolve team is doing, and via the Links network, reaching out to those vulnerable patients, putting extra measures in place, I think is part of the overall COVID response and shouldn't be seen as separate.
And if I can just add to that, there are aspects of hypertension treatment that are really quite important, including increased use of telemedicine, longer prescriptions, and decentralization of care so that there are smaller crowds in hospitals, and so that you're taking the pressure off those hospitals and also reducing the risk to the vulnerable patients. So I think it's quite important that we continue this, the work that we're doing. And in fact, in China, we saw the immediate switch to 3-month prescriptions and welcoming of telemedicine. So there were aspects of chronic disease care that actually were, because they were both needed anyway and very helpful in the COVID response, able to be accelerated.
Great, thanks, Tom. We have a lot of questions that were submitted regarding testing. Maybe you can speak to the process of who should be tested, when should people who think they may be symptomatic go for testing.
Maybe Dr. Frieden would like to take this one.
Mm-hmm.
Yes, thank you. Testing depends very much on the context. So in a country or community where there is not yet known spread of coronavirus, testing is very, very important. And this is why Dr. Tedros from WHO yesterday said testing, testing, testing. Really important to know when it's in the community and where it is so that additional efforts can be made. When you are in an unfortunate situation, as we currently are in New York City, where there are lots and lots of infections, then we would discourage testing of people who have only mild symptoms, because their travel to get tested might result, if they have COVID infection, in infecting other people. And if they're not infected, when they go seek care at a busy health facility, they may become infected, and their testing may overwhelm the healthcare system's capacity for safe care and for tests. Now, South Korea did a remarkable thing in providing drive-through testing, and that's something that will reduce the burden on healthcare facilities, and that's quite important. But the role of it still needs to be clearly understood, because testing is important if you're trying to contain. It's also important if you've got a situation like a hospital or nursing home where there's a cluster that you're trying to stop in a congregate facility. It's also very important for epidemiological studies. And we do influenza-like illness surveillance and severe acute respiratory illness surveillance to learn more about how this virus is spreading. And it's important for special studies to understand, for example, whether asymptomatic people spread the disease widely, which we still don't know. But it's going to be different in different places. It is not a panacea, and there are real limitations to what testing can do. At the same time, it's crucially important in certain circumstances. There is some evidence that it is not highly sensitive. In other words, there may be false negatives, people who have COVID and test negative. So if you're sick with fever and cough in an area where COVID is spreading, if you have trouble breathing, you should go to the hospital. If you don't have trouble breathing, you should stay home and avoid infecting others. Thank you.
Thanks, Tom. We have a few questions, Amanda, about the response in Africa. I know you had a slide on it, but there are a few questions, one from someone based in Nigeria and one from someone based in Uganda about getting the support of the Ministry of Health now that there are confirmed cases in Africa to really mobilize the response in African countries. Can you maybe just speak a bit more on what Links members can do in terms of advocating for support for this?
Yeah, thanks. I mean, I think Afro, in particular, Africa as a whole, presents a challenge to us. That bending the curve or flattening the curve slide that we showed, is potentially a challenge in many African countries where the health system capacity is potentially a bit lower than the countries that we're seeing with heavy transmission now. The capacity to test is a challenge in a lot of those countries, and the surveillance systems are often weaker. And so I think at the moment what we're seeing is just the start of countries being able to detect cases of COVID. And we potentially will see an increase across a number of countries. We see 62 cases in South Africa now, Algeria also reporting a lot of cases, but Senegal increasing their contact tracing and finding cases now. So we see a number of countries starting to report more. One of the challenges in Africa is that there's a lot of other high-risk outbreaks going on. In Uganda, I know they've been challenged by yellow fever and anthrax. And DRC is still in the countdown of the 42 days post EBD, and so there's a challenge in Africa to balance out existing outbreaks, getting ready for COVID, making sure that they think through the different approaches with limited critical care beds, really focused on use of the MPIs effectively, but also managing the negative impacts of those MPIs, including economic impacts. And so the advocacy that we've been doing at country level is really that adaptive response slide, working with countries to understand where they are on the curve, shifting focus from POEs to community level MPIs when they have the information to make that shift, and to use MPIs responsibly and ethically, both in terms of using it to reduce spread, but also making sure that they're communicating clearly to reduce the negative impacts around that. So I think it's really important that the senior medical leaders within the countries advocate for an adaptive response from the ministries to address the risk and to protect the health system.
Great, thank you. How will we know the danger has passed? Or when will we know?
I guess I'll say no one can predict with confidence where this is going or for how long it will last. I think this just emphasizes the need for us to maximize our efforts now and adapt our response as we learn more. Unfortunately, we are in an unprecedented time, and we've seen some countries, notably China, completely control it, but whether that's possible to be done on a global basis very much remains to be seen. Amanda, you may want to say.
No, I agree. I think we, if anyone's saying they can predict it, Tom often says if you say you know, then you don't know enough about the disease. I think it's important to keep in mind that we potentially will have waves of cases, and so potentially we will see improvements in countries, and then as we loosen restrictions on social movement and mass gatherings, potentially we'll see another increase. But there's a lot we don't know about this disease that means we can't predict how long it will take.
Thanks. We have time for a few more questions. Doris has asked, who coined the term NPIs and what happened to societal or behavioral interventions?
I think it's a good question. I think the use of non-pharmaceutical interventions is in the CDC guidance for community mitigation and the WHO guidance, but I think and it goes beyond, I think, just behavioral change because of the economic and legal implications. And so it's an overall kind of arching terminology that we use for non-clinical or non-case management interventions that include trade and travel bans, as well as community intervention. So it's a broader umbrella, I think, of the range of tools and measures that countries are using to flatten the curve, in addition to those personal and community level behavioral interventions.
And Lindsay, there are a few questions on chat. Maybe I can just take them if they haven't been addressed. I have to drop off for a little bit of time, but two in particular I'd like to mention, and then maybe Amanda could speak some about risk communication. One of them has to do with promises of treatment being right around the corner. I think this is unlikely. We hope there will be a treatment soon, but this needs to be rigorously evaluated to see if it works, and then to get the quantities up and see if it's safe. So while we hope there may be treatment that would reduce severity, right now there is no evidence of anything like that anywhere in the world that has leads to the confidence that we would recommend it. Next question is, what suggestions do you have for field epidemiologists responding to COVID, and what role can they play in tracking chronic conditions globally and within the US? This is a very important question because, in my view, the single biggest gap we have now is answers to some of the most important questions. And someone else has asked, do asymptomatic patients spread this infection? And the truth is, we have case reports that this may occur, but we don't know how often it is. With a different virus, the influenza virus, we know that what's called a prodrome, the day or two before people feel bad and get symptoms, there is some spread of influenza, but that's not most of the spread. There is some evidence coming out about the coronavirus, COVID19, SARS-CoV-2, that suggests that in the first week of illness after symptom onset, the amount of virus in the upper respiratory tract, the nose, the mouth, is higher than later in the infection. So what is most likely is that most spread is by people who have symptoms, but we don't know that. And where coronavirus is spreading, field epidemiologists can be very important in analyzing that and in coming up with likely answers to that. We don't know whether children commonly spread this infection. We don't know whether contaminated surfaces known as fomites likely spread this infection. We don't know among people with underlying conditions which are the ones that greatly increase the risk of severity. Is it diabetes in control, out of control? Is it everyone with high blood pressure, or only people who also have heart failure? Is it everyone with kidney disease? We really need good epidemiology. And this is one thing that's been lacking. It's been lacking, I think, in part because where the virus has hit, it has been so overwhelming. And where it hasn't hit, you can't study it. So there's a critically important role for field epidemiologists here. Maybe Amanda, you'd like to address the risk communication question, and then Lindsay, we might have time for one more question or so. There are.
Yeah, Tom, I can't see the chat. Is there a specific question around
But it was
response,
just risk communication is a key strategy. The current approach fuels stigma and fear. Any advice?
Yeah, I think it's a really important question, and the stigma and fear is something that we need to manage. And so the risk communications has to be well thought through and coordinated. I think one of the things that we're seeing is that the health departments and the politicians are speaking with one voice to avoid conflicting messages, and that we focus on the science and the facts. And so I think there's a real challenge here in terms of raising the risk perception so that people understand the need for social cohesion and solidarity, that this isn't just about your individual risk, but the risk to the community. If you're young and fit, you're protecting by staying at home or washing your hands more regularly and following the advice. you're not just protecting yourself, you're protecting your grandmother, your next door neighbor, or other vulnerable people in the community. So it's a real balance between raising the fear enough that you can get the risk perception to a level that you get people to engage and comply with the social and community MPIs, without raising the fear to a point that we've seen in some countries with panic buying. We saw in Italy and in France yesterday, mass movement of people out of quarantine areas, which is actually counterproductive to what the MPIs were meant for. We saw a large influx of people out of Paris yesterday, which potentially will spread the virus over the rest of France, which is not, I think, what the government regulations had in mind. So it's a balance. I think one of the things we're supporting countries to do is consistent social media monitoring. You need to understand what your communities are thinking and what the conversations that are happening on the ground are. Creating this two-way feedback consistently so that you can see how people are reacting to the change in prevalence of the disease, but also the information and understanding of the disease. Rumor monitoring and addressing misinformation is critical. And getting out in front. We're starting to use epidemiology words for misinformation and viral misinformation, early detection of misinformation, countermeasures to misinformation, understanding the networks that misinformation will travel through and addressing those are all important strategies. But I think the main emphasis for us is this regular, consistent two-way communication so that you understand what the conversations at the community level are, and you can adapt your risk communications to that and adapt to the risk prevalence. So you need to change the messages based in terms of where you are on the curve.
Excellent answer, thank you. And a quick answer to the question, does flattening the curve reduce the absolute number of cases, or does it simply spread out the same number over a longer period of time? And the answer is either. Either way, it is going to reduce the burden on the healthcare system. So even if the only thing you do is have the same number of infections over a longer period of time, you've still done a lot of good. But of course, we would hope to reduce the number of infections. Lindsay, do you want to have anything, invite one more question, or shall we close here? How would you like to do it?
Well, so I think the best plan of action will be to gather up all of these questions, particularly the ones that we have not been able to answer yet, and we will try to post responses to them by the end of the week onto the Links website. So apologies if your question was not answered, but I just want to remind attendees that we do have a lot of the resources that Dr. Frieden mentioned at the top of the call on the Links website. If there are additional resources that you would like to see, please email me and let me know. A lot of our Links members have translated some of these documents into their local languages. We are more than happy for Links members to do so. The resources are available to you to be used and posted in your health facilities. Again, we'll just gather all of the information and try to answer the questions that haven't been responded to on this call. But I'd like to thank Amanda, Dr. Frieden, and Dr. Moran for taking the time today to answer these questions. And thank you all for your participation in today's webinar.
Thank you.